So the EORTC lung cancer group, so EORTC is a large European academic research organization, has been conducting clinical trials for the last 60 years. And therefore, we have seen as researchers that over the last couple of years, we have multiple trials in the neoadjuvant setting for non-small cell lung cancer, combining chemotherapy with immunotherapy for resectable tumors. And the problem is that there is no consensual definition of what's a resectable tumor. And this is, on those trials, this was defined by the local teams, the local PIs with their surgeons. And what we feel is that there is a huge heterogeneity in this definition, which makes it hard to generalize these findings to our clinical practice in our day-to-day clinics. So what we thought is that we could try to do a multidisciplinary consensual definition of what's stage 3 resectable non-small cell lung cancer. For that, we asked the help. So it's not only EORTC, we also have the help from representatives from ASLC, ESCS, so the European Surgical Thoracic Society, ESTRO, which is the European Society of Radiation Oncology, and also the European Society of Pathology, as well as ETOP, European Thoracic Oncology Platform, and also the ERS, the European Respiratory Society. So pulmonologists, radiation oncologists, surgeons, pathologists, medical oncologists, all together trying to reach a consensus. We tried to collect as many data as possible on this. So we done a systematic review of the literature, plus a survey that was circulated worldwide and reached over 500 doctors all over the world. A third, there were surgeons, a third, there were radiation oncologists, a third were other specialties, so mainly medical oncologists or pulmonologists. And we also collected over 100 cases of patients with stage 3 non-small cell lung cancer, real world patients from my institute in Belgium. We uploaded the images of their CT scans, PET CTs, and this was reviewed by over 40 experts all over Europe to define what were the cases that were resectable and not resectable. Importantly, this definition is to be used in clinical trials. And here we're trying just to understand the technical resectability. So here we are not trying to say what's the best treatment for the patient. This has to be defined by the MD team, the multidisciplinary team. What we say is just to define what it is possible to be operated or not. And so after gathering all this information, we met face-to-face 6 months ago in Copenhagen, and through the healthy process, because afterwards we had multiple rounds of review online, so in meetings and also by email, and we achieved a consensus. And what are the main conclusions of this consensus? So in one hand, we have the tumors with extensive lymph node involvement, so N3 or N2 invasive tumors, or most N2 bulky tumors that are considered unresectable. On the other hand, we have the small tumors T1, T2, the T3 or the T4 by size, so large tumors, or by the presence of nodules in other lobes of the same lung. So these tumors, when there is absence or limited lymph node involvement, so N0, N1, or N2 single station disease, these are resectable. Of course, then we have these intermediate tumors for which we don't have a definitive consensus. And these are the small tumors with N2 bulky disease, the N2 multi-station disease, for which a careful discussion, case-by-case discussion of highly selected patients must be performed by the multidisciplinary team, and these patients can be potentially resectable, potentially included in these trials. But of course, we cannot say, based on the available literature, how many lymph nodes are okay to be resected. And then we have the T4 tumors, the large T4 that invade nearby structures, the heart or the mediastinum or the diaphragm. And there we've created a table with the different structures. And there are structures that we consider to be totally unresectable, like esophagus or spinal cord. But there are others that are potentially resectable. They have to be discussed with an experienced thoracic surgeon and frequently have to be operated in a dedicated surgical center, sometimes with other surgeons. For instance, if we have an invasion of a vertebral body, sometimes we have to have the help of a neurosurgeon or orthopedic surgeon. So these cases should be referred to high volume centers. So again, this is the consensus that we can obtain with the current literature, plus the perception of the medical community, plus a multidisciplinary exercise. But of course, this can be adapted in the future according to new data that there is released. And the ultimate goal is to improve the inclusion criteria in clinical trials to make them more standardized in order to allow then the application into clinical practice. This has been sponsored by EORTC, but has already been endorsed by many scientific societies like ASLC, ETOP, ESTRO, ESTS, and also patient societies like LUCE, Lung Cancer Europe.